A very good morning to you all. So we'll start with today's program. So I would, before I start, thank you everyone for being here on a Monday morning, on a Sunday morning. I request our editor-in-chief, Dr. PSG Prakash, to welcome all of you.
Thank you, Dr. Manuel. Good morning to one and all. Dr. Manuel said it's a Sunday, and he's been slogging every month, fourth Sunday, with this ISPRP webinar. And hats off to you, Dr. Manuel. It's been a wonderful presentation of scientific lectures every month. So I welcome the ISPRPians, all of you who are gathered here. The whole concept of actually, I promised Dr. Manuel last month also that I would join, but due to some departmental work, I couldn't join on a Sunday. So this time I said I promised him that I will surely make it to this lecture. And welcome, Dr. Vijay Singh. Thanks for accepting our invitation from the scientific chairman.
Thank you.
Yeah, should be a great program for digital workflow for implants. Should be wonderful. I'm looking forward to hear from you. And without taking much of your time, I would like to talk about our first national UG convention. Is that on the panel? Yeah. So first national UG convention for the undergraduates, and it's a host by the SRM Dental College, Ramapuram, Chennai. The venue is also the same. With the acceptance of the President Secretary, we are hosting this program through the head office. So it's a great program for the undergraduates, for them to know which aside they could take in future as a clinical aspect of all three entities will be there. So there'll be a totally 6 lectures. We are planning for a workstation also on navigation implant system. So 3 keynote lectures, 3 video demonstrations, so that the undergraduates can enjoy the thorough knowledge of scientific reputation for all the 3 branches, so that they design and define themselves for the future. And I would like all the participants here to please encourage the professors, the guides, the HODs, the principals, the deans to please support us with this program. Please send your undergraduates. It's on December 15 and 16 of 2023. The brochure has been moving around, and we have got a good amount of entries, but still we are looking at to break few records. So it'll be nice if you could give us a good thumbs up for this program and send all your undergraduates. It'll be a big learning curve for them. And next, I would like to talk about the JIT, which I have taken over as editor-in-chief in 2023. It started way back in 2011. I think the ISPRP itself is the minds of a few interdisciplinarians who came in on a cup of coffee, and they started this one of its kind group. So the whole of India, this is the only representation which we have as an interdisciplinary society. So I would this journal was started in 2011, and the first editor was Dr. Sanat Shetty, and then it slowly grew in. First it was a biannual, and once they saw the demands of the papers coming in, they made it as a 3 issue, and it was Dr. Kundabala who took over from Dr. Sanat, and from there it was Dr. Ashita Upur, and then it was Dr. Sarfaraz, and then Dr. Mahalakshmi Madam, and now it is my turn. So in our tenure, we have 2 issues which we have released from our end. We had almost a good amount of 6 to 5 original articles. The JIT is now, from the last issue, UGC, it's under the UGC care indexing. So it has received the UGC care indexing. So people who are going for NAC and the NAC reputed colleges will consider this as one of your publication, and will get your credit points accordingly as a specialty journal also from the Dental Council of India. So we are looking into make it better. So we are going in for a Scopus, the Science Emerging Index, the Web of Science, as well as the PubMed in the coming months. So most probably by next year, this should be a strong, valid journal, which is the only journal in India to have interdisciplinary dentistry into the picture. So I request all of you to please support our interdisciplinary journal by sending original articles. We are accepting original articles. We are accepting manuscripts on interdisciplinary dentistry, case reports, systematic review, and meta-analysis. As of now, we have stopped a little about narrative reviews. We are working on the strong pattern of indexing. So most of the time, the scopus indexing, which you want to get through, usually wants annual of 20 original articles. So we are marching forwards with that. So once that happens, then we can increase the number of manuscript acceptance. So as of now, our manuscript acceptance rate is 38. So I'm requesting all of you to punch in and please get yourself notice to this index journal, which is there in the online process. So it's open access journal, which is there in online. www.jid. So you can go through the ISPRP.com also, and then from there you have a journal page where you can click on it. It will take you directly to the JIT site, and from there you can read about how you can go ahead and publish it into this journal. So thank you very much, Dr. Manuel, for giving me this opportunity, and all the best to the speaker and to the moderators. Thanks for the Sunday opportunity, Manuel. Thank you.
Thank you so much, Dr. Prakash, for the welcome address. Now it's our moderators. We have two moderators, Dr. Aditi Chopra. She is an associate professor, Department of Periodontology of MCOTS, Manipal. She has keen interest in academics and research. She has a total of 35 publications in national as well as international journals. And she has two patents granted by the Government of India to her credit. She has served as a guest editor in Frontiers in Cellular Infection Microbiology and BMC Oral Health. Second moderator is Priyanka Sarangi. She is working in the Department of Conservative Dentistry and Endodontics at SCB Dental College and Hospital, Cuttack, Orissa. She is a gold medalist in MDS and also has national and international publications to her credit. She has also delivered guest lectures in CD programs. So I welcome both our moderators, Dr. Aditi and Dr. Priyanka, for being here, for sparing time and being with us. Now I request Dr. Aditi to introduce the speaker for today.
Thank you, Manuel, sir, for giving me this opportunity to moderate today's event. I am extremely honored and delighted to introduce to you all a very knowledgeable and esteemed speakers for today's event, Dr. Vinay Singh More. Now, Dr. More is a professor and guide at Department of Prosthodontics and Implantology at Bharatiya Vidyapeeth Dental College and Hospital, Pune. Professor More completed his master's in prosthodontics in 2002, followed by an advanced training in implantology in 2012 from Chanavaz International Implant Institute of Oral and Maxillofacial Implantology, France. Professor More has also completed an intensive training on cadaver and patient-based surgical program in periodontology, including plastic and microsurgery for hard and soft tissue augmentation from the University of Freiburg, Germany. He is currently the scientific head of the Chanavaz Institution of Implants for India. He is the director for the Indian Society for Digital Dentistry and has been a founder member, past president, secretary of the IPS Pune. Sir, we are extremely honored to have you among us, and we are looking forward for you to show your knowledge, vast clinical expertise, and experience in digital workflow in implant dentistry. Without much ado, I request sir to share his wisdom and experience with us. Over to you, sir. Thank you.
I'm sharing my screen. I think somebody has to first give me their access.
Yes, I will give you access, doctor. Yes, you can go ahead and share your screen.
Right. Is it visible? Yeah. So good morning, one and all. Thank you for inviting me to this platform of ISPRP. and it gives me immense pleasure to share my brief work in the field of implantology. Today, I stand here as one of the speakers on digital workflows since I've been associated with implantology for the last more than 17, 18 years. However, my journey in this particular field of digital space started in 2018 when I finished my first Blue Sky Bio certification. And when I was in Spain learning the all-on-4 techniques, I realized a clinician has to have knowledge of both the ends, how to integrate digital workflows at the back end and how to integrate the workflow in the front end as a clinician in front of the patient. In India, the trend was to make a CBCT scan and give all the work to some labs and technicians or the CBCT centers. And with time, I realized I think the implantologist and implant surgeon is the best person to know where to place an implant. So with time, I developed this interest. I have a platform of my own where I have exocad softwares and printers. And today I design most of my guides for partially edentulous cases. So with this background, I'll be sharing few things about digital workflow in implants. And as you can see, I'm affiliated to a couple of organizations, the foremost being my college at Bharati Vidyapeeth Dental College. And I bring my greetings to all of you. Also, I'm founder member at IPS and currently director at the Indian Society of Digital Dentistry. Since last 2 years, we are at the forefront of integrating, spreading knowledge and creating awareness in the field of digital dentistry through this particular organization. At Shahnawaz Implant Institute, I have been a teacher. Today, I head the program. And I'm very happy to be a part of this program because for the first time, we could bring in a lot of European education to India. So I dedicate my presentation today to my teacher, late Dr. Manuel Shahnawaz, who was the chairman for Department of Surgery at Lille Medical University, France. Where I learned my implantology was from Dr. Shahnawaz, who is not a dentist or a surgeon based from dental field. These people, they come from the medical field. So indeed, it was a good opportunity. For almost 9 years, I have spent a lot of time learning implants and spending a lot of time in the OTs. And this is how we started working in Bangalore, in Mumbai and in Delhi. And today with the same motto, we teach implants in OT-based platform to a lot of students, doctors across India at Mumbai and Delhi. However, keeping the agenda short for today, my discussion will be very brief. Since this platform is for multidisciplinary doctors, the agenda is to introduce to the ecosystem of digital workflows, speak something about surgical guides and computer-guided surgeries, share few cases as 40 or 45 minutes would be a very less amount of time. Just introduce one case of patient-specific implants, talk about the pros and cons of this particular science and summarize the presentation. So the core areas where digital dentistry is really working right now, very progressively, is the restorative field, the surgical field, and the orthodontic field. When you talk about restorative field, that is the veneers, onlays, crowns, zirconias, I think when we talk about digital workflows, the only thing that is required is a scanner. So we require maybe a intraoral scanner or lab scan, where you can just plan to fabricate your crowns or aligners. However, when you talk about surgery, we require two sets of informations. One is at the bone level and one is at the soft tissue or the tooth level. So specifically in implantology, we talk about surgical guides where we require integration from DICOM data and the STL data. So these are the two file formats which are available. So whenever you do a CBCT, we get a DICOM data, and whenever we do an intraoral scan, we get an STL format. There are three key benefits of doing digital workflows, that is time, accuracy, and compliance. Today, after doing a lot of cases, what I have realized, when the patient goes for a flapless procedure with precisely positioned implants, with less bleeding, less swelling, and accurate placement. So from the patient end, the patient is happy. And from the clinician's end, you are satisfied that you have placed an implant in the right place. This not only improves the patient compliance, but the patient goes back very happily. And, he's a good ambassador of your good work. And he just keeps talking about the good things that guided surgeries can provide and benefit in the long term. The digital ecosystem can be just broadly, put up in these three phases. The three phases are, begin with the digital ecosystem, you need to record some data for which you require a CBCT or an intraoral scan. This data is then put up in a softwares where the designing process happens. And once the designing part is completed, then the fabrication process will start. I talk about this phases in a different way. So we just see that when we say record, we're actually carrying the information from the real world to the virtual world. So CBCT is carrying the information of the bone, and the intraoral scan is carrying the information of the teeth or the soft tissue. The planning is done in the virtual world. It is using softwares like Blue Sky, ExoCAD, 3Shapes. And once the design process is complete, that information from the virtual world is carried back to the real world, and then we fabricate. The fabrication can be either milling or printing. So milling can be about metals, acrylics, zirconia, or composites, or printing can be about your guides, aligners, or provisionals. So the journey starts from real world to virtual world, work the entire thing or design entire thing in the virtual world, and bring back this information to the real world and fabricate something substantial to finish your clinical steps. So a simple scan like this is about, let's say I'm doing a partial bonded onlay for this particular patient. I just require one particular scan. There is an intraoral scan, or I can make an impression, send it to the lab, and the lab can do a lab scan. So in prosthetics or restorative field, we require only one, surface information. That is the information of your teeth and the soft tissue. However, when you talk about implant workflows are broadly, divided in two phases: your surgical workflow and your prosthetic workflow. And as you can see here, you can either do it freehand or you can do digitally. So surgeries can be done freehand, or the surgery can be performed with a guided surgery approach. The prosthesis also can be done with a conventional impression techniques, or today you can do your scanning and printing and milling. However, let us understand where we stand today in the levels of surgery in implants. Today, I think we are having 4 levels of implant surgical placements. At the bottom of the pyramid is your freehand placement or the brain-guided surgeries. Next on that pyramid would be static guides, or the guides I'm going to discuss today. The third line of the pyramid is your dynamic navigation techniques. And the fourth today is robotics, which is coming up very fast in some of the countries. However, as of in India, static guides have picked up very well. And now slowly there's emergence for dynamic navigation as well. But it proves to be a little expensive, but static guide is something which can be really put up in practice very fast if one decides to. Apart from the conventional implants, where digital workflow is having a significant impact, especially in COVID with the post-mucor cases that we had in Maharashtra, where a lot of cases maxillectomies especially, and we saw an emergence for patient-specific implant. So today I'll share one case of patient-specific implant done for a mucor patient. And these are digitally modified subperiosteal implants with metal printing, that is titanium printing. And these implants, they come with a custom connection. Coming to the core topic of today, that is static guided implant surgeries. A static guided implant surgery is nothing but to fabricate a surgical guide and start using a guided surgical kit to place the implant. How do we call this? Now, a lot of terminologies are existing about this, but the commonly used are a guided implant surgery, and ITI calls it as a computer-assisted implant surgery. They're all the same. A guided implant surgery is a process of planning implant surgery on computer using the patient's CT images and carrying out the same using a guided surgical kit and a custom-made template. So we are customizing this entire design virtually and then fabricating a surgical guide through which we can place the implant precisely in a 3-dimensional position. So static surgical guide is nothing but a template which actually is a connection between a planned treatment, that is what is in your mind, and to the treatment that is to be executed. So it carries the information of whatever you have planned, that is in your mind, this from your brain-guided approach to your digitally precise approach. So by this particular technique, by fabricating this particular template, you can have a 3-dimensional control of placing the implants in terms of your depth, position, and angulation. So as an implant surgeon, these are my 3 concerns. Am I placing the implant in the right place between the teeth? Is it placed buccolingual in the precise position? Am I getting a proper angulation? Because if you're doing, let's say, on all-on-4 and you're planning a 30-degree angulation for a distal implant, is it my precise 30 degree, or is it like 25 degrees, 33 degrees, or 35 degrees? So there are many areas where angulation will definitely matter. So what you need in guided implant surgery is understanding of a surgical guide and a guided surgical kit. To understand the guided surgical kit, this is very important because a lot of people have lesser information of the guided surgical kits. These surgical kits are slightly different than your conventional kits because these surgical kits, they they come with a different kind of a design. As you can see here, the design contains a shank, which is like a barrel. And the surgical guide will have either a sleeve or a slot. So the barrel will adapt to that particular sleeve or a metal tubing. And that is why it is called as a tube in a tube system. A lot of companies in India exist today. The Koreans have been pioneers. And in my personal journey, DO has been very helpful, because when I started my journey in 2018, I got a lot of literature, understanding, and exposure from DO Navi. And Koreans have been really at the forefront from this particular aspect of implants. However, of late, we have been doing with Bredent, we are doing with now with a lot of other companies as well, with Straumann and Neodent. I'm going to share one case with that as well. So, for all people who are into implant field and want to shift to your journey from your freehand or brain guided to your digitally guided surgeries, one has to understand what are the intricacies of using a guided surgical kit. There are limitations of this today's program, because we always spend almost like 2 hours to understand the kit and the protocols of drilling. But whatever I can explain in the short time, I'll do so. So this is a particular drill design. It has got a barrel. These are your the drill end, which is going to make an osteotomy. These are the metal sleeves. And this is how the diagrammatic picture will look like. So this is a surgical guide. This is a metal sleeve. And these are your guided surgical drills. So all these drills will have a stopper. This particular stopper will stop at this particular lip of the sleeve. So this provides a vertical control. So the beginners who are really fearing where my implant will head in, I think this is a good starting point. This is a classic look of another system that was there in India, that is Neodent. And these are your another, a precise kit or very elaborate kit about your guided surgeries. Now, these kits is a previous version where you can see there are metal tubes. And when a surgery has to be done for a guided kit with this particular technique, you need to fabricate a surgical guide. You need to fabricate a metal sleeve. And in the metal sleeve, the drill tubes are placed based on the diameter of your drill. And then the osteotomy is performed. So the drill tube system was like, let's say, the system which was a little older version of the design. And today we are getting away with this drill tube system because very cumbersome to use this particular technique. And today we are just performing drilling because the new kits don't have this aspect here. They directly have a barrel which adapts to the inner aspect of the metal sleeve. The guides can be broadly classified based on the support which they take. So they can be either tooth supported, which is the classical scenario in practice, or in edentulous cases, it can be either a mucosa supported, that is, you are trying to place an implant through the mucosa, that is a flapless technique, or in certain cases, you reflect a flap and then you place the guide onto the alveolar bone and anchor it on the alveolar bone and perform a surgery. So these are the 3 levels or probably 3 methods of designing a surgical guide. We're also evolving in this particular phase now, and today we can see the evolution of stackable guides. So for example, a classical all-on-4 sometimes requires reduction of bone. So if you want to plan a guided surgery for an all-on-4 where there is an irregular bony contour and you want to just level up the alveolar bone, so a guide can be designed where first a fixture is placed on the alveolar bone. It is anchored with anchor pins. Then a second level of guide is anchored onto this fixture. This particular second level guide will have open slots, which will help us to know what amount of bone is exposed about that particular plate. A corticotomy drill can be taken and the bone can be leveled out. Once the bone is leveled out, this particular guide is taken out, and now the implant placement guide is placed. And on the implant placement guide, the implants are placed through this particular sleeves. And today there is a provision even to fabricate a provisional which can be anchored. So stackable guides are called as level 3 guide, level 5 guide, level 7 guides, depending upon how many functions a guide will perform. For academic purposes, this is a classical, what do you say? A classification given by Stumpel. And he talks about the guides being divided in terms of clinical usage. In terms of clinical usage, he talks about depending upon the constraint that is created for a 3-dimensional placement. So let's look at an example here. You do a mock-up of 1-1 and then you fabricate acrylic vacuum form sheet and you want to place an implant through this vacuum form sheet. What information do I get? Probably I can just know where is the center of my central incisor. Probably to a certain extent, I can plan my, placement through the cingulum region. So I can do probably a screw retain prosthesis. So I can get some gross information. But does it control my angulation completely? Does it control my depth completely? No. So these are called as non-limiting designs. The second step in the ladder would be a pilot drill guide, which is called as partially limiting guides. In this particular section, we can only perform that is the first drill, that is the pilot drill guide, after which you have to go freehand. Indications would be a category B bone. Usually in category B bone, as we know, we lose width, but we don't lose height. Such cases are indicated for either expansion, wrist split, grafting. But however, a clinician would want to know the precise position of his implant placement. So in such cases where you are planning to augment that particular site later on along with the implant placement, a pilot drill guide would make sense. I'll just show one case with pilot drill guide. And then we come to the classical protocol where we have to do entire osteotomy through your guide and then place an implant through the guide as well. So these are the three guide types which are commonly used in practice. Coming to the design of the guides, today we have a closed design, which is the conventional design. As you can see here, the guide will cover all the areas of the supporting teeth and the sleeves are open. Sometimes what happens is you don't get a good visibility and a lot of blood, if it enters here, then it affects your surgical performance. So today we are getting open design guides. The open design guides can be either in the form of resin polymers, or today we also get metal guides. So we are getting metal printed guides, and there's a lot of evolution in the terms of design as well for surgical guides. In practice, what we use with the tabletop printers are a closed design guide. So with this background, if I have to put down the possibilities of doing digital workflow of implants, these are some of the aspects that you can do. For the beginners, you can start using a virtual software for planning. Let's say a Blue Sky Bio, then position your implant on the software, select the implant size, and then do a manual placement with a freehand osteotomy. The second level would be, you can plan a surgical guide with the pilot drills. So just do the first drill. You get the exact angulation, position, and the depth with the first drill. And then you can do your surgery with a manual osteotomy and with a freehand placement. The number 3 in the ladder would be a surgical guide for a full osteotomy, but the implant placement is done in freehand. Now the question would be, why would you want to do an implant placement with freehand in certain cases? And I'll discuss that with one case. Surgical guides for full osteotomy with guided placement. Now that's the classical digital workflows in implants. You want to design the surgical guide, do the entire osteotomy through the surgical guide, and place the implant also through the surgical guide. That would be a good objective. And today, we also can have not only a guided surgery and guided placement, but today a lot of companies are providing you with a pre-designed provisional crown. So like an example I showed in stackable guides, you can actually fabricate the provisional digitally in advance and place the crown after the prosthesis after the implants are placed. And the level 6 in this particular progression would be a stackable guide. For example, for full arch cases where you're planning to do some osteotomies, bone reductions, let's say you're doing a all-on-4, maybe it has a pterygoid, it has a zygoma, and you want to plan a digitally placed implant for the zygoma or maybe for the pterygoids. So stackable guides, or maybe you do a conventional all-on-4, stackable guides would be an advanced option in static guides. So this is where we are actually standing today with stackable guides when it comes to the static guide systems. But all this can be combined either with analog or digital workflow for prosthesis. So you have to understand from the surgical end, we have these possibilities, but when it comes to the restorative end, we can still perform conventional techniques or we can perform your digital techniques as well. So how does this work out? So a fully digital protocol will involve scanning of the patient's data, and we require an intraoral scan or a CBCT, then planning and designing. So I'm summarizing these things and designing, and then either doing a print or a mill using a 3D printer or a milling, which ends up giving us a surgical guide, or it can give us a provisional prosthesis. So you can design a provisional prosthesis also at the end of this procedure. How does this go about? So let us look at some of the basics of how this system works. Usually your CBCT is going to give you information about the bone and the teeth, and your intraoral scan is going to give you information about the teeth and the soft tissue. So what happens is, if you look at both these particular data, one thing remains common is the teeth. So using teeth as a medium of communication, the data is merged by selecting 3 diverse points and by integrating this particular data using a software like ExoCAD or a Blue Sky or a 3Shape. So now we have information of all the 3 entities, the bone, the teeth, and the mucosa. Now this particular setup is ready to do an implant placement. So what is the principle here? The principle of guided surgery or digital workflows is also called as a crown down technique. What does it mean? Conventionally, in a freehand surgery or a brain guided surgery, we place the implant and later on we do the impression, send the cast to the technician and then plan the prosthesis. So prosthesis will come towards the end. However, with digital workflows, and now that a lot of things are happening with prosthetically driven concepts, we first plan the position of the proposed tooth, and based on the axis of that particular tooth, the implant position is planned. So this gives us a prosthetically driven workflows which are more harmonious and more biomechanically stable. So this is called as a prosthetically driven placement. And one thing is very important when people start referring these cases to the CBCT centers, the CBCT center should ensure that the CBCTs are done with mouth slightly open and the opposing arch to surface should be recorded. So some part of the opposing occlusion has to be recorded because that is your reference. Based on the position of the opposing tooth, you're going to plan the position of the concerned tooth. Based on the position of the concerned tooth, you're going to plan the position of the implant. That is how it is occlusion-based planning. So implant planning will progress at 3 levels. As I mentioned first, we plan the position of the tooth first. Based on the position of the tooth, we plan the position of the implant. And based on the position of the implant, we plan the position of the sleeve. So after planning all the 3 positions, the tooth position, the implant position, and the sleeve position, a clinician is ensured that he is placing the implant at the right depth, in the right mesiodistal dimensions, in the right buccolingual dimensions, at the same time in proper occlusion. So that's one of the biggest benefits of going for a digital workflow. Once the designing part is complete, we need to fabricate a guide for which the software will give us a design process. And this design process is called as an STL format. The STL format is a language which the printers will read. However, for printer to work, the STL format has to be sliced on a printer software. So this particular guide is taken to the printer software, which either can be inbuilt by the company or it can be a third party. So the printer will slice this entire guide. It will create some supports. And now the printer is ready for printing. So now you can put this particular file into the printer software, and using a 3D printer, we can start printing. Now regarding 3D printing, here are two slides only just to explain the very large science of 3D printing. 3D printing is done on tabletop printers, or it can be done in industrial based printers as well. It requires a different kind of a liquid resin meant only for surgical guides. These liquids, which are meant for surgical guides or for 3D printing, these are nothing but photosensitive methacrylates. So at a certain value of the UV length, they will get cured. The classical being 385 to 405 wavelength. And what is important about the surgical guide is they should have a class 1 or a class 2 biocompatibility, that it should not harm the oral cavity because you're going to use it in the surgical site. And the printing accuracy should be roughly around 100 microns. So the printing layering can be about 100 microns. That is good enough for a surgical guide. If you're doing a prosthetic crown, maybe you're printing a provisional crown, then the accuracy has to go down to 50 microns. So the lower the micron means the better is the surface finish. Currently, there are 3 printer formats which are available in the market. LCD is at the bottom of the pyramid. Then comes the SLA and the DLP. Now, all these particular printers, they have only one thing in common. This particular printer has got something called as vat polymerization. It contains a container in which the liquid is poured. There's a light source at the bottom. And once the file is entered in, there is a platform which is attached here. The platform will come down. And as the printing process starts, a layer by layer buildup is done. So this is called as additive polymerization. And this particular technique, as the printing forms, the platform will keep moving up. As the platform keeps moving up, the printer, the particular guide is stuck on this particular build platform. Coming to the quality of printers, I have mentioned few things here. SLA has been a standard bench horse, and probably it is still in use. It is slow but a very accurate tabletop printer. Digital light processing printers are very fast. They're expensive and for industrial use. The most economic in the market, as you can go on Amazon also and check, LCD printers are very economic. They can be used as tabletop printers. They come in different formats because it's an LCD screen, like a TV screen. So there's 4K and 8K versions are better, but they're not as accurate as other two for large size printing. This is how the platform will look like on a build platform. These are the 3D printed models which are stuck. So one of the most important areas to understand about a surgical guide fabrication is all the guides, these are resins, they're photopolymerized, the curing process is not complete. So there is something called as a post-processing of the guide. The post-processing of the guide involves these following steps. And just to summarize the steps, once the guides are printed on this particular build platform, they are cleaned with IPA, that is your isopropyl alcohol, which is 90% for 10 minutes to remove all the uncured resin. Then they are dried for 30 minutes. Then they are cured for 70 degrees for 30 minutes. Then they are cooled. Then the supports are removed. They are polished with the sandpaper. The sleeves are fixed. And then they can be either sterilized or disinfected. For sterilization, the cycle can be 134 for 10 minutes or 121 degrees for 15 to 20 minutes. And later on, they have to be subjected for a dry cycle for 20 minutes. And if you're not sterilizing, now sterilization is not based on what you can do, probably based on the material the lab selects. If the material is not sterilizable or autoclavable, you have to just disinfect. So for disinfection, we require two liquids. As I mentioned, you can see here, this is a disinfection chamber and the disinfection chamber and a curing chamber. This is a washing chamber and a curing chamber. So for washing, we are using 90% or 99% isopropyl alcohol. This is at the first phase. And for disinfection, we are using 70% isopropyl alcohol. So please understand, a lot of people use the same alcohol for washing as well as for disinfection. It is necessary to understand a pure 99% alcohol is waterless product. And that is why it has got a better capacity to wash the uncured resin from the guide which has just come out of the printer. However, if you want to put the same guide in the oral cavity, you want to disinfect. And this requires a little lower tone alcohol, that is 70%. Now you have 30% water. Studies have shown that 70% alcohol for 15 minutes is a good way of disinfecting your surgical guide. So there are two concentrations of alcohols to clean and disinfect your surgical guides. I just got this picture yesterday and I'm seeing that Telangana is just unveiling the world's first 3D printed temple. So 3D printing is coming up in a big way. It's a technology that is just, filling our lives rapidly. Let's come down to from the theoretical part to some clinical cases. And I'll just demonstrate cases where this is the guide which I have designed. And you can see a patient with a 3-6 with a good occlusal clearance, good mesiodistal clearances. And this is how we start here. So we require CBCT and we require a soft tissue. So I have taken a soft tissue scan of the patient. And here, if you see here, I have scanned the patient's cast. So as I mentioned, you can scan the patient's intraoral, do an intraoral scan, or you can scan the cast. However, the accuracy would be more with a intraoral scan. And that's the patient's CBCT data. So I cannot put up the entire procedure, how to do it in exocad and merging, but I come down directly to the part where the implant planning is done and the surgical guide is designed. So as you can see here, a surgical guide has been given. I can see here virtual implant placement has been done. And this implant placement is done based on 3 things: position of the tooth, position of the implant, and position of the sleeve. After the sleeve position is planned, a surgical guide is designed. And now this particular surgical guide comes out as a separate. So this is an STL format. What you see here is a STL format. So STL format is what your exocads, 3 shapes and blue skies will give you. What is important to understand is this particular format now has to be taken to the printer and the slicing is done. So the printer software will slice it. Now this is how the slicing will happen and the supporting struts are given. So the STL file is sliced on the software and printed, and later on it is cleaned and cured. So once the printing is done, you get this particular uncured probably or resin, which has to be subjected for your cleaning and curing. So what is important here? Important here is whenever a guide is fabricated. Now that's the most important clinical step. We don't call the patient once the guide is fabricated. We call the patient once before the surgery. Why? Because every guide has to be verified. Guide verification is a very important key factor in surgeries. Why? Because many times the guides, usually they crack on placement, they have a certain level of play. So sometimes it's very difficult to insert if you're doing in a patient with a lot of undercuts and the planning has improper. And sometimes if there's an improper fit, you can see there are small windows which are created to check the approximation of the guide to the supporting areas. Anytime you find there are gaps in this particular guide and the supporting to just discard it. You can't play with it. So these are the small, nuisances which can change or alter the outcomes of your surgery. It is better to be wise and then rather than fail at the later end. So coming down to the surgical procedure, as I mentioned, so this is a case which we did with a Cowell-Medi system, and this is a surgical guide. So when my PG was doing this case for the first time, I told her, why don't you just write the protocol? And I just took this protocol and I just put it here for everybody to understand. The guided surgery drilling protocol is slightly different than your conventional drilling. And as you can see here, this is a flapless approach. So it starts with a tissue punch, a bone flattening drill, and then you start doing your basic drilling and then do your final osteotomy drilling and then place the implant. The key factor here for everyone to note is the RPM. Except for one drill that is at the beginning, which is at 1000 RPM with irrigation, all the drilling, everything happens at a very slow speed. So the drilling speeds are somewhere between 50 RPM to your maybe 300 RPM. And why that is so? Because the drills that are manufactured for guided surgeries, because it is a closed-end system and they have to remove the bone from inside, your water irrigation can be less. So if you use a high speed, you can increase, and if the contact time is more, you can generate necrosis. So these drills have a different fluid design, and they come with a very slow speed and they cut very efficiently with a good torque. And it is very important to understand that guided surgery requires a good amount of irrigation between all the change of steps. So there is a learning curve about how to use the drills and what precautions one has to take to ensure that there are no failures because of this contact time of the drills and high-speed drilling and lack of irrigation. So one of the key aspects which I want to really put up on everybody is irrigation. Irrigation is a very important aspect here. So whenever you start placing your surgical guide and you start using your guided drill kit, this is how the position is managed. And as you can see here, the surgical guide is helping the clinician to position, control the depth of the placement and the angulation. What is also important to understand is the role of irrigation. So between every time a drill is changed, one has to keep on irrigating the site. This can be done either by removing this or it can be done through the sleeve as well. The implant placement is done through the surgical guide, and that is why this is called as a fully guided protocol. So whenever I'm doing my osteotomy through the guide and trying to place the implant through the surgical guide, this is a fully guided implant surgical protocol. So here you can appreciate the placement to the surgical guide. Once we are using an engine-driven driver, then we can finish the position of the hex using a hand ratchet. So this allows us to place, let's say you're planning to put your hex on the buccal side or maybe on the distal side. This can be done with a stopper control ratchet. And you can actually control the position very nicely, but it doesn't allow the implant to go beyond a certain depth. And the implant will achieve a specific position that has been planned for this particular treatment. So this is an implant in place, which is a flapless approach. And this is with the gingival former. So we are doing a single stage flapless implant placement. And later on, you can I can just finish this case with using either a digital workflow or an analog technique. And here I have done a screw retained crown for this particular patient. As you can see here, the access hole comes exactly in the center, allowing to give a very good occlusal table for occlusion. So coming down to the second case where you can see some variations. So this is a patient with a 4-6, and this patient, when came to me for implant placement, these are the CBCT data, and the CBCT data shows a good volume of bone. What is critical in this patient was the patient had a very poor mouth opening in the posterior arch. So again, we start with the data here. And as I mentioned, we take the scan data of the upper arch, the scan data of the lower arch. We ask for the CBCT of the patient, and then we plan the surgical guide. So a surgical guide is planned here with a metal sleeve. And the osteotomy is done through the metal sleeve. So this is the tissue punch is the first thing that we first do is the tissue punching. So these are the tissue punch which is just done after using the tissue punch drill. However, because the mouth opening is poor, I can just take out the guide and use the tissue punch and just remove this small tag of the keratinized tissue. Now, here are the few steps. Again, as I mentioned, time would be a factor to consider. So I'll just put up all these videos in one go. And you can see here, we are following this particular drilling sequence. I'm using one drill and I might end up doing both the osteotomies at the same time. So it is very important to understand the drilling workflow, and the systems are very much simple to use because there is a flow chart. So this is the osteotomy done through the surgical guide. Just skip this. However, since the patient's mouth opening was poor, you can see the implant placement is done freehand. That was the first implant, and probably this would be the second implant. So here I'm doing a full osteotomy, but because the mouth opening with the handpiece and through the placement through the guide would be much more difficult for a 4-6 and a 4-7 region, so we have to go for a freehand placement. So this is the post-operative image. As you can see, post-surgery, there's nothing that you can see here, just the implant placement slots. I'm putting a gingival former, and then the surgery is done. The patient is very much happy because the compliance is very nice. He doesn't have any swelling, bleeding, no incision, no flap reflection, no suturing. However, the case selection is important because you need to get a good table to do the entire fully guided protocol. If the bone is a category B bone, I cannot do all these things. I might have to just do a pilot drill guide, reflector flap, do some wrist split, do some augmentation, and finish the case. At the prosthetic end, the thing is, again, we put a scan body here. And as you can see here, we're putting a scan body, and you can see the variations in the scan body. So I'm doing an intraoral scan of the patient. And when I'm doing intraoral scan of the patient, I've chosen a short scan body for the 4-7 and a long scan body for 4-6, because as you go distally, even doing a scanning of the distalmost scan body becomes very tough. So after the scanning part is done, after the scanning part is done, these are the, I forgot to attach my battery. So these are the 3D printed models. These 3D printed models, and you can see here, what we have asked for is a PMA trial. So the technician has given me a 3D printed model. And apart from the 3D printed model, just give him, sorry. So apart from the 3D printed model, we also get a PMA trial. And this is how the model will look like. And now I'm using this particular PMA trial as a jig trial as well as a framework trial to ensure the accuracy of my digital scan. And finally, what we get is a 3D printed cast. And this is the final prosthesis, that is a PFM prosthesis. This is a DMLS prosthesis. So this is again not casting, this is DMLS. And this is the final placement. So you can see here the bone has retained well around the first thread, and there's a good casting fit with DMLS. And I'm not using any abutment from any company. Please understand, today with a lot of digital workflows, you don't require abutment unless and until you want to do on a tie base. So coming down to a second case with a different variation, again, a pilot drill guide in 4-5 region. So this girl was a patient of mine when she was in her 16th and 17th. She had a big lesion here. So my oral surgeon did a surgery here, and after maybe around 3 or 4 years, she came back and she wanted to go for implants. So this was the scan which I did for the patient. And when I did the CBCT, I realized one major problem here. And the problem is the position of the mental foramen. The mental foramen came exactly in the center of this particular place. So the placement was very difficult. Hence, I look at the CBCT data cross sections. Because it was a surgical case, there was some loss at the crest. So this patient required some kind of a wrist split. So the plan here is to fabricate a pilot drill guide. And because there were some undercuts, I did a fit check before surgery. And as you can see that after the fit check and the windows and everything, they're showing a proper approximation of the guide over the teeth, we proceed for the surgery. When you inject immediately around the surrounding areas, you understand the position of the mucogingival junction, and you understand that there is less amount of keratinized tissue. So one of my objectives in the surgery would be to go for a slightly lingual incision and reflect this keratinized tissue from the lingual to the buccal side. So once we do a full thickness incision, I take a saw, and with a saw, I perform a wrist split. After performing the wrist split, you can see a nice wrist split with the saw. I put my surgical guide, and I use this particular surgical guide only for a pilot drill, and I get these two positions. Now using osseodensification burrs, that's a densa burrs, I finish these two sites with densa burrs. So it's like a hybrid technique. I'm doing multiple things in the same place. Straumann Yod implants are placed. And now, because I want to gain my keratinized tissue here, since I have taken a lingual based flap and I am trying to push my keratinized tissue from the lingual to the buccal, I have to put something in between. So these are your 2 mm different kind of cover screws coming from Neodent. So I place these two particular cover screws and then I have anchored the flap on the buccal side. So this is the immediate post-op IOP, and you can see here the angulation that has got, because the mental foramen is right somewhere here. So that was a major challenge. The second challenge was also prosthetics. Because of the angulation, we could not put the two scan bodies together. Neither we could put two impression posts together. So my technician thought of, let us make two scans. So he made two scans of the patients with the scan body separately, and then he merged it. That's the beauty of, I think, digital workflows. This case, without the digital workflow, would have been impossible. Unless and until we go for an angled abutment, but do a prosthesis. But I think the outcomes would have been far inferior. So making two different scans and merging these particular scans, the technician was able to print this particular guide, and I asked for the tie basis, and this is the DMLS scopings, and these are the tie bases in place, and this is the post-op, this is the tie base IOPS showing the approximation of the tie bases over the implants, and this is the final placement of my tie bases. So what I'm doing is tie bases and PFM usually is glued by the lab. But this time I wanted to intraorally. So my challenge was so I finished this case intraorally. So the DMLS PFM is usually luted on the tie base by the technicians, but I said, let me lute it intraorally because I have to position them and use a conventional dual cure resin and lute it. As you can see here, one of the objectives was to gain the keratinized tissue. Just by reflecting some of the keratinized tissue on the buccal side, the objective also, apart from placing the implant, was to get a decent amount of keratinized tissue. A 2 mm keratinized zone is what you're looking at for your stable soft tissue management over the implant. Coming down to a little more challenging cases, and this patient was referred to by my dentist colleague, and the patient was traveling from Singapore to India. He visited this particular dentist for the extraction of these two teeth and implants. However, there was some problem. And the problem was evident when the patient's CBCT was done, and you can see a huge palatal cyst here. The palatal cyst left no bone, and there is only some bone left at the nasal floor. He called me up and said, like, sir, can you just do something about it? The patient has traveled all the way, and can you take some chance and do some surgery for this patient? I called the patient, I showed him all the CBCT and I showed all the scan data, and I said that this is not a case for immediate placement, but he said, I have taken a 10 days leave and can you just try something? I said, I'll give a try, but I am not sure about the outcomes. So here, the planning was to extract the site and to just enucleate everything internally. And here I fabricated a surgical guide over the extraction sockets previously. And this is the metal sleeve for the Neodent implant. And the two implants were placed. Sorry for this picture, but the next picture is much clearer. The implants were placed after curettage and bone grafting. And you can see I've used the Neodent 16 mm implant, which is anchoring the nasal floor. So this is the advantage of having multiple systems in practice, because they offer a 16 mm implant. Most of the systems will offer either 13 or 15. And we could go deep to the nasal floor. And you can see some amount of grafting been done in the cyst. And look at the parallelism that I got by using a surgical guide. However, let me also share one of the concerns. One of the implants didn't have torque, not even 10 NCM torque. I told the patient very clearly that this is not a good case and the outcomes can be negative at times. But he was happy. He said, like, I'm okay with that. Even if it fails, it is fine. So this was the grafting to just close the jumping distance, to close the site. And this was sutures were given just to ensure the graft remains stable. But the patient was traveling back, so I made some Maryland bridge with acrylic. And this is the adjusting the Maryland prosthesis for the time being. The patient went to Singapore. This was his immediate picture when he was leaving for his hometown. And when the patient was in Singapore, he made an IOPA, but at the same time, he sent me a picture. And during, I think, around 6 or 8 weeks, the patient developed some amount of reddishness and some kind of a swelling thing here. He went to a local doctor and he made a IOP in Singapore, and the doctor confirmed this looks like a soft tissue issue, but the implants, they look pretty much stable. So the fingers were crossed and probably the implants also were integrating positively. The patient returned after almost 5 to 6 months. And then this was the position when he returned. And you can see here the soft tissue was almost healing well. there was some shrinkage and there is small gap between the teeth and the soft tissue. And then I did this scan for the patient. So this was the scan for the implants. Let me run through the scan. So these are the scan bodies in place. The scan body position also helps us to understand the emergence of the tooth and the angulation in relation to the opposing arch. So you can see here now, the angulations can be very well visualized. So we can give some tips to the technician. The final process was done as a DMLS PFM, and this was the picture after the cementation of the prosthesis for DMLS PFM on a tie base. Again, all my cases are on tie basis. And this is the patient at active smile. We wanted to match the angulations with the opposing arch. And the patient was happy. My fingers were crossed. This is a case where I was not sure about the implant success. But I think there are miracles when implants which you feel are going to fail, they succeed. And sometimes the implants which are very sure about, they fail. Coming down to the last case of this particular category would be an FMR case. And I'll just try to run quickly because I think we might overshoot time. Please let me know when to stop. I can immediately stop.
Sir, one question we want to ask, like as you told, CBCT has been done, and after the CBCT, we place the guide and the implant, and the patient develops some necrosis, something. So most of the time they compulge that you remove the implant.
Can we? Can I just request? Can we take Q&A towards the end because I have few slides to complete.
Okay, right, sir. Okay.
Is it okay? Is it okay? Yeah, because I think I have a couple of cases to share and my closing thoughts here.
Sure, sir.
I'm going to share a full mouth case, a full mouth rehab, and maybe a PSI case, and then probably I'll close my presentation.
Sure, sir. Sure.
This is the
Please let me know when to stop, but because this is a time constraint, I can stop anytime. I can just go give my closing comments. This is a full mouth case. So I'm just trying to show the different aspects because this is the last case where I'm going to show about a full mouth rehab and then come down to one case of PSI, and then I think I'll be over. So this is a full mouth rehabilitation case with a edentulous patient. And the patient, whenever now this is something which is important for all the doctors here to understand. Whenever we are doing an edentulous patient, we do what is called as a dual scan technique, where we do CBCT. So the laboratory will give you a record base with some radiographic markers. So these radiographic markers are already built in with the record basis. And the patient has to go and make two CBCTs. CBCT of the patient with the JR and CBCT only of the JR. So these two CBCTs are then merged by the lab. At the same time, the JR has to be mounted to check the inter-arch space. So my request to the prosthodontist, to all my colleagues here is always in a full mouth rehabilitation case, ensure that you are doing your diagnostic mounting and evaluating your case, the inter-arch space, because there is a classification, we call it as FP1, that is fixed prosthesis 1, 2, and 3 remote prosthesis. So whenever you want to plan your full mouth cases and whether you want to assess whether I have to go for a removable or maybe a hybrid denture and all-on 4 or FP1, FP2, diagnostic mounting and inter-arch analysis plays a very vital role. So the implant planning is done on 3 shifts. Now this case is not being designed by me. It has been done by the DeoNavi plan. So as I mentioned, this is done in Delhi. They have a center, official center. And the plan mentions 6 implants in the mandible, 6 implants in the maxilla, a small cantilever on both the sides. At the same time, they said that we might require some sinus grafting in the second quadrant. So these are the cross sections with each particular section here. Very difficult to describe every section now. But what we get here is a surgical guide with the metal sleeves and the anchor pins. And this is how we tried to check the fit of this particular guide. That was the maxilla, and this is the mandible. So once we confirm the position, fit, and the quality of the guide, only then we approve. If there's any problem with the surgical guide, you just discard and tell the lab to do a new one. Please don't proceed with anything which is wrong with the surgical. So on the day of surgery, the surgical guide is anchored onto the maxilla and the mandible, and osteotomy is done following all the required steps. So these are the only 1 or 2 videos about, one for the maxilla and one for the mandible. And implant placement is done with a flapless technique. In the first phase, we placed 4 implants in the maxilla, leaving the sinus grafting later. And in the mandible, we finished all the 6 implants. So at the stage 1, we finished with the maxilla 4 implants and the mandible 6 implants. Let me also give you a very unbiased opinion. In mucosa supported guides, because of the resiliency of the tissue, sometimes you might encounter problems with the depth of the implant. So as you can see here, we had to modify some of the positions of this particular implant and this particular implant. This is how we get as a diagnostic or treatment plan from DeoNavi. Usually they give you all the drill sequence, whatever has to be used. In this particular case, I have done a guided sinus lift or a guided maxillary sinus grafting. So DeoNavi has a separate kit for guided sinus grafting. And this is the guided sinus grafting plan, wherein we use certain hydrolift techniques where they're specially designed drills where you can perform the hydrolift and then through the guide, you can graft it and place the implant. So this is a very new experience and a controlled experience of doing guided surgeries. However, we need to remove the guide because I wanted to place the Nova bone putty graft and then I place the implant again back through the guide. And this is the final placement. And I can see the amount of graft that is there around the implant. So this is the final outcome. These are the 6 implants with the multi-unit abutments in the maxilla and in the mandible. And with the impressions, we went up with the conventional technique with open tray post, then probably do some splinting, open tray impressions with custom trays and polyether, a jig trial. And whenever we do a jig trial for full arch cases, we do what is called as a Sheffield's or a 1-screw test, where we just put all the impression posts on the implants and then try to only connect 1 screw and see that the other part is not lifting. That's the verification of your jig trial in a full mouth cases. So this is a jaw relation of the patient. Then we do a phasebow transfer. This is mounting. So first the teeth arrangement is done to know the position of the teeth. This is verified. And now this is scanned. So the teeth arrangement is scanned. And then the same information is used to fabricate the coping. So whatever copings are fabricated is from the information of the teeth setting, which has been scanned and put up in the software. Once the coping trial is done, there are a few things that you check in the coping trial. And these are a few things which are mentioned here. A definitive prosthesis is done, which is a screw retained prosthesis, and it also has some amount of gingival component. Whenever you do a full mouth prosthesis, occlusion becomes the key, and there are 3 prominent positions one has to verify in full mouth rehabilitation: anterior guidance, the left side excursions, and the right side excursions. So this, as you can see here, are showing some canine contact. So this is the mutually protected occlusion, where bilaterally there is no contact between the posterior teeth. And similarly, in the anterior guidance, there is disclusion between the posterior teeth. So either a canine guidance or a group function, both can be valid depending upon the patient's maxillary positions and based on the patient's orthognathic parameters. So this was the post-op OPG of the patient. As I mentioned, in the maxilla, we had a small cantilever even in the basic treatment plan. So we could achieve a level of accuracy, which was based on the diagnostic planning. And as you can see here, the healing after 6 months, and all the implants are very well submerged in a bony contour. There's a very good amount of healing. And the patient's prosthesis looks very much pretty satisfactory in terms of the design, with a lot of clearances between the metal and the bone. So this is the patient's view. Sorry. If you look at the facial parameters, look at the lower facial height before treatment and after treatment. And the patient was very happy. She came from a rural background, but that's why, but she was pretty much happy with the outcomes. And that is what your full mouth rehabilitations can do to the patient. So coming down to the last case of the day about patient-specific implants, and digital workflow really revolutionized the way today we are treating our maxillectomy defects or mandibular defects. So this patient developed mucor and she reported to our department with a small defect. So for the time being, we gave a RPD to the patient. And the RPT was pretty okay, but she wanted a fixed prosthesis. For a fixed prosthesis, we asked for a facial scan, that is a patient CT data. And this patient data, we have a manufacturing company in Pune, which manufactures 3D printed titanium frameworks, which are customized. It's called as 3D Incredible. So I don't have to go outside Pune. So again, we do an intraoral scan of the patient to record the soft tissue data. And now the design team sits. So this particular case was done between Department of Oral Surgery and Prosthetics. So my colleague from Oral Surgery and my unit. So his unit and my unit. So my students and his students were working on the team together. And this is the design of the custom-made implant. And you can see here the right side implant design, the left side implant design. And as you can see here, I requested the company to design the zygomatic strut because the framework was sitting on the labial aspect. We don't have a vertical stopper here, and we don't have a vertical reference plane. So as an implant surgeon, you can suggest whatever design specifications you want. The number of holes for osteosynthetic screws at different locations can be advised. And the best part about it, you can customize your connections. So we're using a Korean platform here. So what you can see here is this particular custom-made implant will have custom-made connections which are designed for all the Korean systems. So this is a design of this particular implant from an occlusal view. You can see here how this custom implant moves around in different planes. And this entire thing was printed in titanium using the DMLS technology. So in Bharati Hospital, we have EO sterilization. So we sterilize it in a medical hospital. And this is the framework when it came after printing. And this particular struts are the extensions that will come in the oral cavity. And they have an internal connection which is matching with all the Korean 11-degree conical connections. So this is the final design, the 3D printed implant. And this is how it looks on the model. So on the model, this is the 3D printed facial, the skeleton of the patient. And the implant is adapted. And we look at how is adaptation. If there are any gaps or if there are any contours, you can discard the design. They can print a new one. But adaptation has to be verified on a 3D printed model. And then we go to the OT. So in the OT, since my training has been through the OT protocol, it was easier for me to attend the surgeries in the OT. And our team, we perform the surgery under GA. And these implants, as you can see here, so they help us to reflect the flap, give a good position. And then we together probably try to fix the framework, put the osteosynthetic screws, and orient the implant in the right place. As you can see here, the design specification which I mentioned for buttressing at the zygomatic buttress and at the zygomatic arch helped us to position the implant in the vertical plane. So this is how at the end of the suturing, we see the studs here. In the same appointment, we also attach the multi-unit abutments, the height of which is selected based on the emergence of the soft tissue and the required height that is needed for the prosthesis. Protective caps are placed in the same appointment and immediate PA view is done. So we do it in our own department, radiology department, and this is what we get. And we compare it with the position of this implant. So this is a custom-made prosthesis on the 3D model, and this is the CBCT. And we were okay with the kind of level we would achieve in placement of the implant. At the same time, at this particular stage, you can see here, before the implant was placed, we placed some titanium cylinders and we scanned this entire thing. And after scanning this entire multi-unit abutment, we fabricated a pre-milled temporary prosthesis. So, as I mentioned in the beginning, you can place a guide, you can place an implant, and you can do a prefabricated prosthesis. So this is like something like a level 5 of implantology, where apart from a guide placement, you can do your prosthetic placement. So prefabricated prosthesis was designed before the implant could be placed in the laboratory. And then it was immediately inserted after a few days when the patient's edema and the basic healing was clinically okay. So this was the patient at the time of provisional prosthesis. So once she recovered from GA and her basic health and orientation was fine, I think we went on place the immediate provisionals and the case was finished later. So this is the team of Department of Prosthodontics and OMFS. So these are my colleagues from the surgery department. These are my residents. And this is they said like, let us take this picture in the OT. So we're immediately in the OT just after finishing the surgery. However, before I end my presentation today, I want to just make a statement here. Guided surgery is not a panacea. It is not something I can do for every case. So just give a small example. Again, you can see here, I took this picture from one of the designs coming from one lab from my department. You can see the logo of our college and everything. And when I looked at the close picture here, you can see here, the position of the upper arch is somewhere here. The position of the bone is somewhere here. And the sleeve position is somewhere here. The position of the implant is in the center of the bone, but the prosthetic position is somewhere far lingual to the opposing arch. So the clinical dilemma is, are you doing a guided surgery for bone-driven work or prosthetic-driven work? If it is for a bone-driven work, you don't require this particular guide. So I just told him this is not required. So there's a lot of misunderstanding about guided surgeries. You have to understand that you have to get your tooth position right. So maybe the plan would be a little different. Maybe the orientation would be somewhere here. Maybe the patient might require some grafting or a wrist split. Maybe change in angulation of the implant. Whatever it is, a guide cannot justify the means. Justice cannot justify the means because the objective should be clear. Am I working in the prosthetic envelope is something what should guide your workflows. If it is freehand, fine, it is freehand. If it is guided, fine, it is guided. But a tool cannot be misused in this way by just getting a good position of the implant, which doesn't have any role with the prosthetic or the occlusal aspects. So please understand, guided surgery is not something which is going to solve all your problems in clinical life. It is one good tool which has a very specific role with a very specific techniques, and it has to be customized for every patient from freehand to guided, from guided to freehand in the same patient. And this understanding requires a certain level of learning and certain level of experience. So I never advise guided surgeries for people who have done at least 25 implants freehand. Please don't venture into this field immediately. Get a feel of freehand surgeries and only then start your journey in guided workflows. So coming down to few closing slides, guided surgeries do offer a number of advantages, especially when you talk about the proximity to vital anatomy, proximity to the adjacent root, especially the canine and the premolar region in the maxilla. It can be a very good tool even in extraction sockets or in grafting sites where you can use a pilot drill. It can be also very important. In fact, is one of the most important factors in the aesthetic zone, because if you get implant placement that is right, the prosthetic envelope or the prosthetic emergence of the restoration would be very nice. So guided surgeries have a huge role in the aesthetic zone. And from the clinical end, the patient requires, hardly requires any flap reflection in many situations. So patient is very much compliant. There is less feeling, bleeding, pain. By the end of the second, he doesn't feel anything. He feels there's no implant done. However, any science is not complete because every science will have some kind of complications and errors. And here I'm enlisting few of them. One of the major things which you can see with guided surgeries and documented in many literatures is there's definitely a small deviation in some cases between the implant that is planned and the implant that is placed. Most of the deviations, they happen at the apical end and not at the crestal end. And the deviations can be up to 8 degrees. The deviations can be up to 8 degrees. However, there can be also errors which can be because of data acquisition, surgical template production, the quality of the resin that is used, post-processing changes, the software and the hardware of the printer. For example, if you're using an LCD or an SLA or a DLP, it depends on what kind of hardware you are using, how the resin has been cured and cleaned, whether it leads to any kind of a shrinkage, whether there is an error in the design of the guide, the placement of the guide. All these factors they play. Another error can be because every surgical guide has to go through that particular sleeve. A small gap has to exist between the drill and the sleeve. So this small gap can also lead to a small mechanical error, also called as a burr cylinder gap. Similarly, as I mentioned in one of my cases, it cannot be used very effectively in the patients with poor mouth opening in the posterior arch. There can be a lot of movement sometimes during Kennedy's class 1 or a class 2. For example, if you have missing posteriors and the anchorage is only on the anteriors, sometimes the rocking can happen in the posterior arch. If you're going for a mucosa supported guide, there is a lot of problems with stability unless and use an anchor pin very effectively. In flapless approach, you have to be very critical in maintaining the keratinized tissue. Anytime that you feel that the keratinized tissue would be lost, please avoid flapless approaches. There can be fracture of templates and guides, and there can be loosening of cylinder and sleeve. There are many situations wherein we're trying to do an osteotomy, suddenly one sleeve pops out and comes in the oral cavity. And you have to be ready for all the situations. All in all, it requires a certain level of learning. So to summarize this presentation, digital dentistry is an integral tool of current restorative and surgical practices. It is minimally invasive, it is accurate, it is time-saving and patient-friendly. In implant surgery, it can be a very good tool for flapless, regular, tilted, or remote implants. When I say remote, is pterygoid and zygomatic. However, whenever bone grafting or soft tissue challenges are there, it will always pose a major challenge. Offering a range of simplistic to complex issues or solutions, digital workflows will become an indispensable tool in coming years. Recently at ISDD, I published these articles, and this is for your reference. One was regarding the intraoral scanners, about the concepts, the techniques, and the comparative review. And the case I just showed you, also we got published as a full mouth rehabilitation case for the edentulous patient in guided surgeries. So through ISDD, we are creating a level of awareness about guided surgeries. And through my institute, where we've been doing a lot of surgeries, we're also creating a lot of awareness about implantology per se, because we offer an extensive 2-year diploma. And this was a recent convocation that we had. And this is my current director, Dr. Shahnawaz. Again, as I mentioned, they're medical grade surgeons, and we do a lot of cases under their supervision and under the guidance in the OTs. And from everything, right from GA to zygomatics to iliac crest harvesting, intraoral grafting, extraoral harvesting, everything. So with this, I would like to thank the Indian Society of Prosthodontics, Restorative and Periodontics for inviting me to the session. A special mention to Vibha Shetty ma'am, because she, she just suggested that, can you come as a speaker on one fine day and share your experiences with implants. So thank you, ma'am, again for inviting me. Thank you, everyone, for patient listening. I wish this particular association very best for the upcoming congresses and all the team members. Thank you once again for patient listening. Thank you.
Sir, one question.
Thank you so much. Before the question answer session, I would request the participants to post the question in the chat box, and our moderator will be asking the questions, because we have only 10 minutes for the question answer session. So please post your questions and we'll get to the discussion. Thank you so much.
Very good morning to one and all. That was a very interesting and insightful lecture, Vijay sir. I'm sure the presentation definitely helped all the participants to upgrade their knowledge on implants and digital workflow of implants, and they will definitely apply these principles to their day-to-day clinical practice. So let us move on to the questions that were posted in the chat box. The first question is, can we plan the surgical guide for immediate implant placement cases?
Of course, like I showed you one case on extraction, if it is a case, let's say a single missing tooth, or wherever you have a support of the adjacent teeth to give a good support to the surgical guide, it can be done. But if you are asking for full mouth cases also, today with a stackable guide, we can perform extractions very well predictably. However, whenever we do, there's a variation here. If you're doing an surgical guide for two supported cases, the workflow is very much simple. But however, you're planning an immediate extraction for a full mouth case, the workflow would be different. Rather than relying on a, let's say, tissue supported guide, one has to go for a bone level guide. In a bone level guide, because we are taking anchorage from the bone, it is easier for us to extract the site. And if you want to plan some leveling or we want to remove some interdental crest, plan the table, then the bone level guide is good enough. But let's say in your planning phase, after the extraction, you find that the implant placement doesn't require any bone changes, then you can go for a tissue level guide also. So the answer is yes, but the workflows are different.
Okay, thank you, sir. So the next question is, which is the good bone tissue graft?
Which is a bone?
Which is the good bone tissue graft?
Bone tissue graft. Either there is a bone graft or there is a tissue graft, like mucoderm or a mucofibro guide. So I think there are two different things. You can have a bone graft or you can have a tissue grafting, which is your your allografts. For example, coming from, let's say, Geislich has a muco guide, fibro guide. So usually, if you talk about a soft tissue graft, which is alloplastic or allograft, you have something called as one for the connective tissue called as a fibro guide, where you want to increase the keratinized tissue. And if you want to increase the keratinized zone, you have to go for a muco guide, or that is a guide which allows you to just generate a keratinized tissue and which can be exposed to the oral cavity. So fibro guide is different and muco graft is different. So these are grafts which are intended for different purposes. As far as both graft is concerned, it's a huge science. You have right from autogenous bone to alloplast to allografts, xenografts, everything is possible. So I don't know what is the nature of this question. If there's any specific thing that is required, I can answer, because the graft itself is a big topic.
Okay, sir. Another question is, what is the cost for fabricating a surgical guide for single tooth implant placement?
Like I mentioned, nowadays I don't fabricate guide outside. I have my own facility. Since I have my own facility of scanning, I have an ExoCAD software, I have Blue Sky software, and I have a printer. So of late, I have not given anything to print outside except for a full mouth cases if required. Because I didn't mention one thing here, even though digital dentistry is working very well in single tooth cases or partially dentulous cases, today still you can come across errors in full mouth cases. So full mouth rehabilitation with digital surgery or guided surgery, or with specifically with scanning, I would say. Scanners, when they do full arch cases, and sometimes you might find this lack of precision. So when it comes only to the surgical part, let's say printing a guide, for example, if I check it out in Pune, you can the price point can be anywhere between 3,000 to 5,000 rupees for a single, because depending on the number of sleeves that you are planning, the cost goes up.
Okay.
I think that is the cost, somewhere between around 5,000 would be the cost for, maybe 3 to 5,000 would be the cost for one sleeve. And if you're doing an all-on-4 guide, they charge somewhere between 12 to 15,000 rupees, maybe even less.
Okay. Sir, the next question is, should we use digital implantology for all cases?
should we use digital implantology for all cases? No, as I mentioned, I made a very clear statement there that digital implantology is not a panacea. It is not something that you can use it for all cases. There are cases which might require maybe a prior bone grafting only. Maybe you require a prior, like I mentioned, you have to, cases will be customized. You have to go from freehand to digital, from digital to freehand at cases, especially in cases where you require bone grafting procedures, where you require some kind of augmentation procedures. All these cases would require digital. One thing which can you actually do is you can plan or stagger your treatment. For example, if you're doing something like a Khuri's technique or a split bone technique, where you want to develop your bone in the posterior arch, you can plan the bone augmentation as a freehand. Once the bone has has been developed, then you can scan the data and then plan the implant placement with a surgical guide. So the answer can be yes and no, depending upon in what situation we are handling. Like I mentioned, and it's very clearly said, only when you have a good bone conditions, the category A bone, where you have a good volume, okay, that is where flapless surgeries and guided surgeries work really well. However, if you're having a category B bone, that is loss of width, but there is a good height, you can go for a bilateral guide and then do freehand and then finish a case. I showed you one case where we did a sinus grafting. So that is category C bone. That is a sinus grafting case for indirect approaches, category C bone. So that case would require a guided surgery through the sinus grafting, but it requires a steep learning curve. But also let me just mention here, if it is a category D bone posterior maxilla, where there is no bone absolutely, then today you get surgical guides for the window technique also, the lateral window technique. So in such cases, you can plan the osteotomy of the window through the guide, finish the osteotomy, put the graft, come back after 3 months. So some advanced surgical options are coming where everything can be planned digitally. But in today's time, it does not take away the importance of freehand implant placement. Please understand that there is a cost involved to it. There is a lot of back-end work involved in it. Guided surgeries can go wrong if the integration is very poor. Guided surgery can go wrong if the guide is not properly made, not properly cleaned. So it requires a lot of hard work and a lot of back-end work. So 75% back-end work and 25% front-end work. So if you have the time and the energy to give that particular time and focus to this particular treatment, it can be put up in many cases. But otherwise, freehand surgeries will have a role in practice.
Thank you, sir. So the next question is, which is the cheapest but pretty reliable digital implant which you would suggest for a beginner in digital implant methodology?
No, there is nothing like pretty cheapest. There's nothing like cheapest implant. Cheapest implants are all there in the market. You can go and just search. All the Israeli implants would be cheaper. The next in line, the middle level implants would be, let's say category D implants are your Israeli implants. Maybe category B would be somewhere a little bit with a conical connection. The Korean implants come with somewhere in category B or a C position. And then you have premium implants like Nobel and Straumann and the other companies. I think all the implant systems, in spite of their whatever position in the market, they all provide digital platforms today. So if you're looking at a company like Aiden, or you're looking at a company like Cortex or Alpha Bio, a lot of companies which are there, I don't know because I don't use them. You will find digital workflows happening with all these companies today. As far as established companies are there, definitely even the Korean systems are also coming down, and all the premium systems are also coming with the surgical setups or the digital setups. I think it is across the industry market, all the companies are providing digital workflows today. So you can just look at any company which can give you a cheap implant and a digital workflow. One more thing I have to mention here is it's not about you and me, it's also about the technician. Whether the company is available, providing the digital data to the laboratories, whether the data is accessible as an open library, whether the technician is able to integrate the same data in his software, and whether he is able to perform those procedures correctly at his end also. So it is when it comes to digital workflow, it is about the doctor, the patient, and the lab. If you have a good patient with good indications, a good doctor who can perform a good surgery, and a good system which can be integrated well, and the laboratory is able to give and deliver, I think why not? Any system can work with digital workflows.
Sir, another question is on all-on-4 treatment. Can we rely on Paulo Malo guide, or is a digital surgical guide preferable for all-on-4?
Guide, I think, are we talking about all-on-4? I'm not sure. Paulo Malo, there are two aspects to Paulo.
Yes, sir.
Paulo Malo is for example, individual who designed all-on-4 techniques. So a classical guided surgery where 2 implants are straight and 2 implants are tilted can be very well designed with the this particular aspect. As far as Palo Malo Bridge is concerned, where Palo Malo Bridge is a hybrid prosthesis which has got 3 components: a titanium framework, individual ceramic crowns, and a gingival wrapping around it, either with composites. So it is a prosthetic workflow. So prosthetic workflow can be easily done with a scanning protocol. So I think if the question is understood clearly, we can perform regular all-on-4 techniques with a standard surgical guide, because you can easily tilt, you can get a sleeve of that angulation. I could not show one case. I have done a digital guided all-on-4 from start to end with scanning and 3D printing. But today, since the time was short, I didn't include that particular case. So yes, everything is possible. Even the remote anchorage is possible. You can do your zygomatic implants through digital workflows. It can be customized by the companies. They can call Dr. Zygo or something else. By Norris will have some other name. You can do pterygoid implants with this. You can do all-on-4. Today, a lot of people are doing nerve bypasses. Like your basal implants, they put an implant outside the buccal bone, which looks like it is crossing the mental, your inferior alveolar nerve. But the implant lies buccal to the your mandibular nerve. So a lot of possibilities exist with implant placement with guided surgeries.
Due to lack of time, we'll take the last question.
Okay, the
Dr. Rahul's
last
question.
Yes, sir. The last question is regarding ridge augmentation. Your views after implant placement about tissue regeneration and implant-supported teeth occlusion guidance.
I didn't get that question. Seriously, I didn't get that question. Can you please repeat the question? Let me just put it in, just dissect that question.
Sir, your views on ridge augmentation.
Ridge augmentation. Yeah, ridge augmentation is pretty much a very standard protocol nowadays. If you look at the ITI protocol in extraction sockets, they talk about the early loading protocols. So in ITI, you don't do immediate implants. Usually you just wait for 4 weeks for the soft tissue to heal properly. And then when the oven bone is formed, you try to place an implant. But ITI talks about contour grafting or ridge augmentation. Those say that whenever you do an implant in the extraction socket, please put some xenograft and put some blood liquid. They're called as a biologic medium, and try to contour it. So augmentation along with the implant is possible. Augmentation in the extraction socket also is possible. And augmentation over the implant is also possible. I think ridge augmentation is a very well documented technique. I don't think there is any ambiguity about bone augmentation around implants. Coming down to soft tissue augmentation, my suggestion would be augmentations can be done separately. You cannot do bone augmentation and soft tissue augmentation at the same time. Because my interest is in microsurgery and soft tissue management, this is always, I always tell a lot of people that don't try to do too many things at the same time. Try to stagger that thing. Maybe if you want to place an implant, the right time of augmentation would be at the implant placement only. At the implant placement time, if you can just, like I showed in one of the cases, you can just mobilize the keratinized tissue from the lingual to the buccal, is a good time. But let us say you lost the keratinized tissue after the implant placement. So during the healing phase is the best time to do your soft tissue surgery. So the implant is placed and the implant is healing, osseointegration is happening. Maybe you can take a connective tissue graft from the palate. Maybe you can take a ready-made graft from some companies and put it there, depending upon what is the objective of soft tissue surgery. The objective of soft tissue surgeries can be 2. Increase the bulk of the keratinized tissue or increase the width of the keratinized tissue. And both have a different purpose, a different method, and different application techniques. So this has to be understood depending upon what is the objective of the surgery. So the answer to this question is in 2 facts. Bone augmentation, yes, very well established. It can be pre-op, intra-op, or post-op. Your soft tissue surgeries, 2 objectives. You have to decide whether you want to change a thin biotype into thick biotype, that is change in thickness, or whether you want to change the keratinized zone. Let's say there is 0.5, you want from 0.5, you want to go to up to 2 mm. That is change in the keratinized tissue width. So these, based on this, you can select the technique, but I think Zucchelli's technique and all are very well established to give you both the objectives of soft tissue management.
Okay, that's all. Thank you, sir, for clarifying the doubts of our participants. And thank you so much for sparing your valuable time today for the lecture. And thank you to Manuel Thomas, sir, for providing me the opportunity to moderate the Q&A session. Thank you, everyone.
Thank you for moderating the session. It was a beautiful presentation by Professor More. So that's why I love ISPRP. We get to hear from the stalwarts, live sessions from the stalwarts itself, directly from the mouth. So again, Professor More, beautiful presentation with clinical cases.
Thank you.
I would, from the ISPRP, from ISPRP office, we would like to again thank you for sparing your time and being with us. So this is a certificate of appreciation from our side for our speaker. Thank you so much, sir. And for two moderators,
Thank you.
Dr. Priyanka and Dr. Aditi, thank you so much for being here. And big thanks to our participants for being here, for supporting us. Before I end, I would like to tell you that for the certificate, the feedback form has been, link has been sent. Once you fill in the feedback form, the certificates will be sent to you to your email ID. And we have exciting news. We have so many good speakers lined up. So one is digital smile designing, and some people had asked about bone grafting. We have a talk on bone grafting in the month of Feb, and on conscious sedation in the month of March next year. So thank you so much, everyone, for being here and participating in our event. Once more, thank you so much, Dr. More.
Thank you.
Thank you for accepting our invitation.
Dr. Manuel. Thank you. Thank you, everyone, again for inviting for this event. Thank you.
Thank you.